Hello everyone. Today we'll be talking about the role of cilastatin in cisplatin-induced nephrotoxicity. Uh, cisplatin, as you all know, has been used and is still being used as a as a as a chemotherapy for various different cancers, and we all know about the risk factors of cisplatin-induced nephrotoxicity and and how much it causes nephrotoxicity in different patients. Up till now, the best defense is to use hydration in these patients, and we are going to discuss the possible role of cilastatin in future. Again, this study was done in rats. Before, they have only been in vitro studies, but this is the first study that was done in an animal model, and that was in rat. So. Um, let's see what cisplatin is. We all know that cisplatin is an antineoplastic agent, which is a platinum analog and an alkylating agent. It is used to treat various different solid tumors like bladder, ovarian, cervical, head and neck, non-small cell lung cancer, mesothelioma, etc. Uh, how does it work? Once cisplatin is inside the cell, it is bioactivated by hydrolytic reactions. The chloride ligands are replaced by the water molecules inside, uh, and then they convert the platinum into a mono and di aqua diam amine platinum species. The aqua species react with the DNA, creating intra-strand DNA cisplatin cross-linkaging that causes the cytotoxic lesions in the tumor cells, and in this way it stops the tumor growth. The next slide will show you a cartoon as how cisplatin causes damage to the cytotoxic cells, and this cartoon was taken from lipoplatin. And what this slide is basically telling us is that once the cisplatin inside the cell, it causes activation of different apoptosis genes. It causes activation of caspases, and it also causes direct apoptosis through activation of P53 and different apoptotic genes, which causes apoptosis, transcription factors, up or down regulations, and the DNA repair. Um, if we look at the cisplatin nephrotoxicity, we know that non-proliferating cells are not affected. The exception is the proximal tubular epithelial cells. So usually cisplatin affects the new plastic or rapidly dividing cells. The exception is the proximal tubular epithelial cells. Lee in 2009 proposed that around 25 to 35% of patients can have nephrotoxicity following a single dose of cisplatin exposure. And there has been several pathways that have been suggested for nephrotoxicity. It causes increased pro-apoptotic proteins called BAX. It decreases the pro-apoptotic proteins called BCL2, and activation of caspases have all been proposed. Overall, there is an increased oxidative stress, which is the final outcome causing nephrotoxicity in these patients. So, looking at clinical features of cisplatin nephrotoxicity, basically what it can do is it can cause a chronic renal insufficiency that can be progressive, and above all, it causes a proximal tubular damage, which causes hypomagnesemia, Fanconi syndrome, salt wasting, and anemia. Um, and your urine output goes up. What we always forgot about is the potential possibility of a thrombotic microangiopathy, especially when given with other nephrotoxic agents like gemcitabine and bleomycin. So let's see who are at risk. Rees et al. Proposed that the initial cisplatin dose of around 50 to 140 milligrams per meter square can be significant enough to produce cisplatin toxicity. They propose that the free platinum concentration of more than 400 nanogram per ml is associated with 30% chance of decline in GFR by the fourth course of therapy. This platinum concentration is solely for research purposes, and we do not check the platinum concentration in our daily practice. So overall, initial dose or the cumulative dose of cisplatin is one of the risk factors. The other risk factors include the previous cisplatin exposure, pre-existing renal disease, and up till now there is no threshold that has been identified, but the consensus is to but the consensus guideline says to avoid it if the serum creatinine is more than 1.5 or the GFR is less than 50, and if you have got a concomitant administration of potential nephrotoxic agents, and older age females, if you have got a smoking history and hypoalbuminemia. What is recommended? A lot of agents have been tried to avoid cisplatin nephrotoxicity, and data is really variable. The best recommendation is to use the lowest possible dose of the drug, use saline pre and post administration to promote diuresis, and if possible, avoid using it in patients with CKD with a GFR of less than 60% unless used as a curative agent. Uh, Very recently, amifostine has also been proposed to work against cisplatin-induced nephrotoxicity. So a little bit about amifostine. Amifostine is an organic thiophosphate. What it does, it donates a protective thiol group. So instead of, remember, the chloride getting replaced by the aqueous species and making cisplatin active, the chloride species is replaced by the thiol group. It is given before the treatment, and it is used in a phase 3 clinical trial in females with ovarian cancer, where 6 cycles of chemotherapy was used in cisplatin with cisplatin exposure of 100 milligrams per meter square. Um, it showed that amifostine decreased the incidence of nephrotoxicity by more than 40%. It showed the sorry, it showed that the amifostine decreased the incidence of nephrotoxicity from 33% to 10%, and the nephrotoxicity was defined as more than 40% reduction in creatinine clearance. Because of that study, and I don't think that we can see it below here, but that study was proposed by CAM, and that was presented in Clinical Journal of Oncology in 1996. Because of this study, the American College of Clinical Oncology in 2002 proposed amifostine as a potential drug to prevent cisplatin-induced nephrotoxicity. What they wrote down, that amifostine could be considered in patients receiving repeated administration of cisplatin for ovarian or non-small cell lung cancer. It was again reiterated and updated in 2008 guidelines. So what are the arguments again amifostine? We don't see it that much routinely administered with cisplatin, and the arguments are as under: the dose of cisplatin, the study through which the amifostine was initially proposed as a potential protective agents against cisplatin-induced nephrotoxicity. The dose of cisplatin in that particular study, which was done in camp, uh, uh, the dose was much higher than the dose that is now being used. The study was only done on non-small cell lung cancer and ovarian cancer patients, and not in other cancers where cisplatin is also used. The potential anti-neoplastic effects have also been seen with amifostine. What this means is that amifostine reduces the anti-neoplastic effect of cisplatin, and it has significant side effects with nausea, vomiting, and hypotension. And it was also noted to be very expensive. A dose of 910 milligram per meter square is proposed, and a 500 milligram injection costs anywhere between 1,000 to $1,500. So what else is there? And this slide is from various is taken from Up to Date, and what I'm trying to tell here is that so many different substances have been used, or chemicals or compounds have been used with varying effects, but unfortunately up till now none of these have got a potential role in preventing cisplatin induced nephrotoxicity other than hydration alone. And that this is the reason why I'm presenting this article today, and it talk about the cilastatin as a potential drug to protect against cisplatin induced nephrotoxicity. So what is cilastatin? uh, that's the compound there. Cilastatin is a chemical compound which inhibits the human enzyme dehydropeptidase. Now, this enzyme dehydropeptidase is found in the kidney, and it is responsible for degradation of an antibiotic called imipenem, and that is the reason why cilastatin is combined with imipenem, and we have got an antibiotic called premaxin. So the role of cilastatin is to prevent is to prevent the breakdown of imipenem through preventing this enzyme dehydropeptidase. So this is the only clinical role of cilastatin up till now, is to use it with imipenem to form an antibiotic called premaxin, which basically stabilizes the imipenem. So the study, coming back to the study, the objective of this study was to see if cilastatin can reverse the effects of cisplatin and uh, on cisplatin induced blood body weight loss, meaningly urine output in rats. Whether cilastatin can prevent cisplatin induced renal injury, whether it can change cisplatin induced morphological renal damage, whether what's the effect of cilastatin on cisplatin induced apoptosis, on oxidative stress, on incorporation in renal cortex, and finally what was the effect of cilastatin when it used together with cisplatin on the cancerous cell. Because as we discussed before, amifostine as well as N-acetylcysteine or the mucomys, the main side effect or the main drawback of those drug is that it has got anti-neoplastic. It can have the anti-neoplastic effect on cisplatin, and therefore it can reduce the efficacy of cisplatin. So this study also addressed on that, whether cilastatin reduces the anti-neoplastic efficacy of cisplatin. So why cilastatin? Why not any other drug? So in vitro models, and I'm giving you the references below. In vitro models of toxicity of renal proximal tubular epithelial cells, cilastatin incubation had showed marked protection. Unfortunately, before this current study, there was no clinical relevance of these findings were presented on animal models. So those all studies were in vitro models, and fortunately, cilastatin had very good effects on reducing the cisplatin-induced nephrotoxicity. But this is the first animal study, so that's why I was interested in presenting this. So the model or the subjects were rats. It was a Spanish study, and it was published in Kidney International in June 2012. The material used were the porcine RPTEC Raptax, or renal proximal tubular epithelial cells. Those were obtained to provide a DHP, dehydropeptidase 1 activity assay. And again, as we discussed, DHP is very specific to Raptax. Cervical, breast, colon, bladder cancer cells. Cancer-derived cell lines were obtained from HeLa cervical cancer cells. HeLa cells were incubated for 24 hours with increasing concentration of cisplatin. They used 200 micrograms per ml in the presence and absence of cilastatin. Apoptotic nuclei and caspase 3 were used to analyze the apoptotic activity, and the study performed on and this study was performed on a 7-week-old male Wistar rats. So let's talk about the design. So total number of subjects that were rats in the study were 30. The control were 7. So in the control nothing was done. The 7 rats only cilastatin were given. Cisplatin were not given to them. Just cilastatin were given. In 8 studies, in 8 rats, only cisplatin was injected, and then in remaining 8 rats, both cilastatin and cisplatin were injected. So the dose of cisplatin was 5 milligram per kg. The dose of cilastatin was 75 milligrams per kg BID from day of cisplatin injury. These doses were taken from previous in vitro studies. Cilastatin was injected before cisplatin injection, as we discussed. Dose of cisplatin and cilastatin was selected on previous in vitro study, as what I just said. in causing nephrotoxicity and protection. So what this mean is that we already know from in vitro studies that this dose of cisplatin causes nephrotoxicity um, to in vitro study. 24-hour urine was collected a day before the rats were killed. Immunohistochemistry in Western blot were used to detect antibodies. DNA fragmentation as an index for apoptosis was also used. So let's talk about the results. In table 1, I'm showing here the effect of cilastatin on body weight in cisplatin treated rats. So what do they mean by that? They are basically trying to say what the urine output was like. So the change in weight in the rat was basically because of the urine output. And this here is saying that as compared to only cisplatin treated rats, the rats that were treated with both cisplatin and cilastatin had minus 13 gram less weight loss. Meaningly, in rats in which only cisplatin was given, they had more nephrotoxicity in terms of proximal tubular damage, causing polyuria and therefore more weight loss. Um, this table is telling us about the GFRs here. So in rats who were treated with both cisplatin and cilastatin, you can see that the GFR is relatively well preserved as compared to cisplatin alone. If we look at the urine volume, they were losing more urine, or they had more polyuria or more proximal tubular damage in only cisplatin versus cisplatin and cilastatin, or the treatment group. The treatment group had less proteinuria, as we can see here. And this diagram is basically giving us the morphology of the rat tubules. And what this diagram here, number A, is showing the control, the kidney biopsy of the controlled rats, and you can see here that it looks very normal. B and E here is showing rats who were treated with cisplatin. This is the renal cortex, this is the renal medulla, and you can see here that you can see sloughing of renal tubules here. You can see this sloughing, that the tubules are already being blocked, and so is in the medulla, as you can see here. Compared to control and cilastatin, where the morphology is normal, and you can compare it with control, looks very normal. So cilastatin on control does not have any effect on tubular damage morphologically, and this is the treatment group. So cilastatin and cisplatin, renal cortex, renal medulla, and you can see and compare it from here, the nephrotoxic effect of cisplatin is less as compared to cisplatin alone. And this diagram here is in magnification. You can see that there is vacuolization and there is sloughing of renal tubule, and as compared to the treatment group, the tubular injury is less significant. The kidney injury scores in treatment versus non-treated patients. So this group is treated with cisplatin, and this is a treatment group where cilastatin was combined, and you can see that the kidney score was around 12 to 13 in cisplatin alone, and in combined treatment group with cisplatin and cilastatin, the kidney injury score was only around 5. The next slide is showing the tunnel positive cells. The tunnel is the terminal deoxynucleotide transferase, the TDT, mediated DUTP NIC. Basically what it's trying to say is the apoptotic activity, and you can see that in cisplatin the tunnel positive cells were high, as close as 4 towards as compared to cisplatin and cilastatin, where the activity was much lower. This slide is telling us about the caspase 3 expression, and remember the caspase 3 was involved in more oxidation and therefore more nephrotoxicity. And you can see that in rats who were given cisplatin, you can see that there is more caspase 3 activities as compared to the rats where cilastatin was also given. And not only caspase 3 but the procaspase 3 and the cleave caspase 3 activity was more in cisplatin um, versus combined cisplatin and cilastatin. This diagram is showing the caspase 9 activity. The previous diagram showed the caspase 3. This is the caspase 9 activity. Again, the caspase 9 is also activated and also shows your oxidative stress. And as we can see here that the caspase 9 activity or expression was more in cisplatin versus combined cisplatin and cilastatin. And in a log form as well, you can see very nicely that in rats that were treated with both the cisplatin and cilastatin, their caspase 9 activity was much lower than the rats that were treated with cisplatin alone. Uh, this is showing the BAX upregulation, and you can see that the BAX, which are the apoptotic genes, were upregulated more in patients in rats. I don't know why I'm saying patients. In rats that were treated with cisplastin versus combined treatment group of cisplatin and cilastatin. And so is the BCL2, as you can see here. FAS-L ligand more exposed than cisplastin versus cisplatin and cilastatin combined. And cleaved caspase 8 again more expressed in cisplatin versus cisplatin and cilastatin combined. H2O2 measurement, which again shows your oxidative stress, more in cisplatin alone and less in rats when cilastatin was combined with cisplatin. The antioxidant activity was improved significantly when cilastatin was combined with cisplatin, as you can see here. Again, catalase activity was also improved in cilastatin versus cisplatin alone. And heat shock proteins, which are the proteins that are produced in response to any injury, was more in cisplatin versus cisplatin and cilastatin combined. Now this is a very important slide which is showing what can be the effect of cilastatin on cancer cell. As we discussed before, that the reason why other agents were not that much successful, or they were not used that much, especially the N-acetylcysteine, was potential anti-neoplastic effects on these drugs on cisplatin. And what the oncologists were concerned about is when they use the drugs like mucomist, for example, it reduces the anti-neoplastic effect of cisplatin. So obviously they want to avoid these drugs. Now this study also looked at the effect on cilastatin when it was combined with cisplastin, to see whether it reduces the anti-neoplastic effects of cisplastin or not. And as you can see here, the anti-neoplastic effects were not decreased. In fact, when cisplastin was used alone here versus when cilastatin was induced, you can see the antineoplastic effects were nearly the same. Versus in Raptax cell, which is the renal proximal tubular epithelial cells, you can see that when cilastatin was combined with cisplastin, there were less cells that were dying as compared to when the vehicle alone was used, which is cisplastin. So just to summarize, cisplatin nephrotoxicity is a real problem, often resulting in holding further administration of chemotherapy in already very sick patients. Animal study with cilastatin is really promising, and I've just presented you the first study that was done in this regard. Unfortunately, there are no human studies, and the human studies are needed to explore the validity of this study. And last but not least, I would say that Cilastatin is definitely a new kid on the block. And with that, I thank you for listening this presentation.